All right, let's jump right in. Welcome back to Part 13 of our Mastering Myocardial Infarction Coding Masterclass. Today, we're zeroing in on a super specific and, honestly, highly technical area of the manual. We're talking Type 5 MI, Post-CABG complications, and those incredibly strict surgical sequencing rules you absolutely have to follow to get your claims paid. If you've ever stared at a post-op cardiology note and thought, wait, which code goes first here, you're in exactly the right place.
So here's our game plan for this explainer. We're going to define Type 5 MI, nail down that master code assignment for I21.A9, dive into complication sequencing guidelines, figure out how to tell graft failure from progressive disease, and then wrap it all up with a real-world case analysis.
Section 1, Defining Type 5 MI. Before we even touch a code, we've got to understand the clinical picture, right?
Take a look at this 3D bypass model. A Type 5 MI, or T5-MI, is entirely unique because it's directly tied to a coronary artery bypass graft, a CABG surgery. So unlike your typical Type 1 MI that's caused by, spontaneous plaque rupture, a Type 5 is explicitly linked to this specific surgical revascularization procedure. Pathophysiologically, why does this happen? Well, it usually comes down to a few specific triggers. We're talking about an MI that occurs because of the CABG procedure itself, maybe an acute graft occlusion, a non-atherosclerotic graft stenosis, or some other severe intraoperative ischemia right there at the bypass site. Basically, when a provider documents that a heart attack was a direct complication of a newly placed bypass graft, your brain needs to immediately jump to Type 5.
Moving right along to Section 2, Master Code Assignment I21.A9. Let's step out of the OR and open up our coding manuals to check out the tabular hierarchy for this. The absolute foundation for this diagnosis is code I21.A9. This one is specifically carved out for other myocardial infarction type, and it explicitly covers Type 5 MIs linked to revascularization. But, and this is huge, so definitely pay attention here, this code does not fly solo. The tabular list gives us some very strict instructions we have to follow.
This is where the concept of progressive disclosure comes in. It's kind of like building a story with your codes. Step 1, you've got to follow the code-first rules for post-procedural disturbances. Think I97.190 or I97.790 if they apply. Step 2, you assign that I21.A9 for the Type 5 MI itself. And then Step 3, you absolutely have to follow the code also note to capture the actual mechanical complication, something like T82.218- for a bypass graft occlusion. See how that works? You're painting the full clinical picture.
Okay, Section 3, Complication Sequencing Guidelines. We've got our codes, but now comes the real puzzle, sequencing them. Which one actually claims that top spot as the principal diagnosis?
Well, Section G of the official guidelines gives us the final word on this. It says, when the admission is for treatment of a complication resulting from surgery or other medical care, the complication code is sequenced as the principal diagnosis. So the major takeaway here, the mechanical complication of the graft absolutely takes priority over the MI code, assuming the admission is specifically to treat that complication.
Next up, Section 4, Graft Failure versus Disease. Before we tackle a real case, we need to sidestep a massive coding trap, the exact kind of thing auditors love to catch, which was highlighted back in Coding Clinic Q4 of 2016.
Here's the deal. You have to clearly separate an acute device or graft failure from the natural progressive atherosclerosis of a bypass graft. They are not the same thing. If the graft fails because of an acute mechanical issue, like a sudden occlusion or dissection, you're looking at the T82.18 category. But if the doc notes that the graft is stenotic because the atherosclerotic heart disease just progressed over time, you're heading down a totally different path to code I25.810. Remember, acute failure is a complication. Natural disease progression is not.
All right, Section 5, Real-World Case Analysis. Let's see how this all plays out in practice, shall we?
Here's your scenario. A patient comes in with an NSTEMI caused by the acute occlusion of a saphenous vein graft. This patient also has a history of a previous 2-vessel CABG. Now, think back to that Section G sequencing rule we just talked about, and the tabular instructions for I21.A9. Which code needs to be listed first?
Let's look at our options. Option A leads with the mechanical complication, then follows up with the Type 5 MI. Option B completely flips that, putting the MI first. Option C throws the post-procedural disturbance code in the front. And Option D leads with the complication, but tries to use a standard NSTEMI code I21.4. So, which one actually follows our guidelines to the letter?
If you went with A, spot on, because the patient was admitted to treat the graft occlusion, which, remember, is a complication of their previous surgery. Section G says that the complication code T82.218A has to be our principal diagnosis. Then, following our tabular instructions, we drop in I21.A9 as a secondary diagnosis to catch the resulting type 5 MI. Option D? That was a trap. An MI caused by a graft occlusion is distinctly a type 5, definitely not your standard type 1 NSTEMI.
Coding post-CABG complications really demands a sharp eye for clinical detail and strict adherence to those sequencing guidelines. When you break down the clinical anatomy and follow that Section G tabular hierarchy, you are setting yourself up for totally accurate claims. But, it does make you wonder, what other hidden coding traps are just sitting there in your cardiovascular charts waiting to trigger a denial? Keep studying those guidelines, guys. Thanks so much for joining me for this Masterclass Explainer, Decode Healthcare with Harshal.